You're about to see a short interview with Dr Richard Barclay from the Orchard Medical Centre in Kingswood, South Gloucestershire. We're going to be talking about the Wellbeing Project, a social prescribing service delivered by staff from DHI working in partnership with the team at the Orchard. Richard, can you tell me what prompted you and the partners to think about doing something different with patients?
Well, we were really keen to try and see how we could do things differently. We did some work with a clinical psychologist, and they simply asked, why do you come so often to patients that came very often? And the reading was actually quite distressing. We often don't meet these patients' needs, yet they still come. And one of the problems with that is that the GPs can get embroiled in this and then over-medicalise the problem, often doing more tests or prescribing perhaps more than necessary. So we felt that the skills that DHI had married really well to try and give a non-medical approach, and it was that partnership that really helped this project lift off.
How did everyone get on board with the idea?
Well, it was a fairly slow burn, really. We'd seen people like community matrons or caseworkers in the past, and we wanted to look at a non-medical way of working together, and we created quite a vision which I think was quite important for us winning the contract that allowed us to do both this and a wider project under the APMS.
From your perspective as a GP, how did the service work in the practice?
It took us a little while really to work out what we were trying to do. So we used GP referrals, nurse referrals, and we also searched the GP database to see what patients might benefit most from this intervention. We knew we weren't setting up a clinical trial. We did this as a pilot. So it's always difficult to then get the outcome data that you really want to prove a change. So we've got trends of data which are very encouraging, and we've also got lots of anecdotal stories of things that were really quite life-changing.
Can you describe a typical patient that you might have referred to the service? What sort of issues would they present with?
So no, really, I think that's the whole point. There wasn't a typical patient. We tried to, or DHI tried to really look at the patient as an individual. An example that we all talk about was a diabetic man who was in and out of hospital. And when people sort of said, why is he going in and out of hospital? We realised he didn't have a fridge, he couldn't store his insulin, he didn't have regular food. So DHI enabled him to get the help that was already there in the community, but he was unaware of, and put two and two together. So he got his fridge and food packages. And it was that kind of thing, not duplicating what was out there, but helping people to find the help that's already exists in the community and has already been set up.
What difference did the service make to you as a GP, and were there any practice-wide benefits?
Well, unfortunately for us as a practice, the funding came to an end as our APMS service was decommissioned. But what was really good is that the evidence we created during this pilot allowed us to help DHI to put the case, and actually they've successfully won the project in Bath, which is up and running now, and that's taking the project a step on. We do need to think much more holistically when we're commissioning, and we use that term holistic so often, yet I think what this proves to me is when we have medical services commissioned, we need to think about the patient and their wider priorities. It may be that they don't want the services that we think that they want, or aren't in a position to accept them. So that's the important bit for me, is that we think not just about their medical needs.